Right. Okay. Can everyone see me? And see the
Yes.
slides. Brilliant. Good afternoon, everybody. Thank you so much for the patience. I hope you're able to get your hot chocolate. I need to stress on hot chocolate because that is always not represented. Coffee and teas. Right. So my name is Dr. Adeniji, and I am very much involved, within the EDI space at different levels. I'm a GP partner and trainer at Eleanor Cross, and also Patient Joint Clinical Director for the ARC Hub. And nationally, I'm the chair of all GPs, in the first 5 years with the Royal College of GPs. But from the EDI perspective, I've also been quite involved in terms of group strategy with University Hospitals of Northamptonshire and a lot more other opportunities. I think my main aim today really is to, because we almost see, we think about EDI and it's just that tick box we need to think about. But I think I wanted to bring it home, in terms of thinking about practical ways that we see EDI, come alive in our different settings, especially in primary care. Interestingly, a lot of the speakers before me have, done really well to touch on several of the points we will kind of touch on, but we won't dwell on it too much because they've done a much better job at that. And, collaborations have been key. So a lot of the speakers today, we've been able to collaborate at different points really throughout the year. Anyway, so we're moving on to this session. And in terms of the objectives, to explore the importance of, EDI in primary care, identify challenges, biases, think about possible adjustments, and accessibility, which I think has been, we've touched on that already, really, and commit to practical actions that we can implement in our different surgeries. Can you all see the slide move? Just make sure I'm not talking to myself from that perspective.
Yes, we can, yeah.
Brilliant. Right, so why EDI in primary care? I think the first thing, even before going into this is going to be our safe space, okay? And I'm hoping to hear from you in terms of, some questions we'll be touching on, but also giving practical examples as well. So a lot of us know about the Equalities Acts that have come through and, thinking about the characteristics that are protected, and all of that is important. And interestingly, I get to teach our lovely registrars preparing for AKT, and we're able to actually see how EDI comes alive in primary care. And the truth is, we live and breathe, EDI is embedded in every component and ultimately improves patient outcomes, reduces health inequalities, which we've touched on today very well, and also builds inclusive teams. And usually I think a lot of people are guilty of, and this is unintentional, guilty of focusing on just the patient, but not thinking about how EDI comes, within our workforce. How do we embed that within our workforce, really? So hopefully you get the time to reflect on some of these things throughout today's session. Right, and I'm hoping to hear back from a lot of you as well, really, through all of this. Health inequalities, we've touched on this. Again, without dwelling too much on it, it's important to think about what we can do. And there's been different projects that, that have come through, Oana and Gabby, Marcella, doing amazing things, really. So there's a lot to think about, but one thing I think is often missed out, which I think a lot of clinicians, or not just clinicians, people in general are not fully aware of, is this core 20+5. And for me, I think it's important, if you're even thinking about quality improvement, I love the idea of quality improvement. This becomes an opportunity to say, okay, where do I start? Because oftentimes healthcare inequalities, all of that, it just seems like this big, big terminology, really. It's how do I practically implement it? So I think for me, coming up with this, this framework that has been created by NHS England, I believe it was led by Professor Bola Owolabi and her team at the time, it kind of breaks down beautifully where you can begin to sort of target, especially if you're thinking about population health management. You're thinking about your core 20. So that would be your 20 most deprived 20% of the population, usually with the IMD, really. That's the index of multiple deprivation. The plus group would be patients that often, for various reasons, some of which we've touched on, they often experience, poorer outcomes, or for whatever reason, they're not actually captured within the general framework of the core 20. And then the 5, and an example, by the way, for the plus group, you've got people from minority ethnic groups, you've got people that are homeless, asylum seekers, refugees, people like that are not often captured, in the core 20 part of things. And then you've got the 5. The 5 represents key clinical areas of health inequalities. And these are areas that would be good to focus on. Again, ideas for quality improvements, pick on one of it, start small. And I remember having a discussion, I believe it was with Julia then, around, projects and all of that. I was trying to think big, but she was emphasizing on the elements, and it was interestingly powerful to see how you can start small and see the results, and then you can obviously scale up, really. So these are the 5 areas: maternity, severe mental illness, chronic respiratory disease, early cancer diagnosis, where there's a lot around screening uptake, really, which, different groups have been looking into, and then hypertension case finding and optimal management. And then smoking cessation just cuts across, all of those, really. So that's just looking at it from the healthcare inequality side of things. This question has already been asked. If you still want to fill it in, feel free, in terms of the biggest barriers your patient face. And actually, for me, it's often interesting because you see all this data. You see all this data about, okay, across Northamptonshire, it almost makes you think, actually, no, that's not us. We're fine. We're good. My patients are all, well, mostly fine. But sometimes it takes you reflecting and maybe engaging with your patients to actually understand what are the biggest barriers. Appointment availability. Absolutely. Thank you for putting that through. Absolutely. And interestingly, today is quite symbolic in terms of, opening up our appointment slots with the new changes. It'll be interesting to find out how you're all getting on with that. But yes, so the truth is our patients face different barriers. And again, it's also important to realize that you're not alone in all of this. Your practices are not alone. And I think this is where it's fundamental. We begin to have a conversation, as to what barriers, communication, absolutely, accessing online appointments, absolutely. How do we address it? Okay. And again, this is an ongoing, absolutely, digital exclusion. Thank you. So these are things we need to think of, really. Now, moving forward, like you've all rightly touched on, some of the examples I came up with: digital exclusion as well, screening uptake gaps, access to consultations. Now, the screening uptake side of things, I know there's a lot of work going into that, and, in terms of communicating, because we need to let people know what is available. There is misinformation out there. And a lot of people, because they talk within their communities, this is where I am big on the idea of collaborations with our, champions that are in the communities. I think there is room for us to engage with them a lot more. And usually I hear, oh, we don't have time. And it's true. It is true. We don't have time, but we can leverage on the connections already in existence, really. And I stress on the collaboration side of things because I have seen that practically come alive, particularly this year. And my example is around hypertension case finding. So within the Black and Afro-Caribbean community, obviously, when we think about risk factors for hypertension, that is, a risk factor in itself. But I have noticed the pattern where we're seeing under 40s actually, already have high blood pressure. And usually we think hypertension, we're thinking of those in their later years and all of that. But I wanted to see if this was actually true. I was just making it up. And over the last year, we engagement with different teams, but it's not, a lot of it was using opportunities really. So I'd be invited to speak, to young people across Europe, as well as that. I'm also saying we need to think about your health. We're doing the checks together. And interestingly, you're seeing 25 years old patients, 20 years old patients with blood pressure systolic to 190, 200. And they're telling me, oh, that's how it's always been, But I usually get headaches sometimes. And this conversation starts outside our clinic walls, okay? And this sort of collaborations have been useful because I've increasingly seen a lot of people who are then beginning to take their health seriously from an earlier stage because of such conversations. Part of that would be a collaboration with Health Watch, so Gabby that was on here earlier, as well as Dr. Marcella Day at the Northampton Carnival, again, engaging with people, letting them know. And in that discussion, other things often come up. From blood pressure, we then go on to screening issues, really screening uptakes. And then for some people, it's about menopause because we don't often talk about these things or don't have enough times. Anyway, all of this to say, there are opportunities out there really, and we need to take the time to see how we can leverage on these collaborations to make a difference. Based on the data gathered in the last 1 year, it turned out that about 65% of those that had high blood pressure were under the age of 40 years old. And that for me is important. It's significant really in terms of addressing health. So anyway, let's look at ways of collaborating. We've talked a lot around health inequalities, so I wouldn't dwell too much on this, but the truth is there's a lot of room for improvement in this area. Even if you think about the language, for example, that is something else, but we'll come on to that a bit later. So it's an afternoon, I know it's quite busy. I've got this riddle on here. I'd love to find out your thoughts about it. And preferably for this one, maybe you want to put the responses in on the Teams chat for this particular riddle. So a father and son are in a car crash. The father dies and the son is rushed to the operating room. The surgeon says, I can't operate on this boy. He is my son. Who is the surgeon? I'd love to hear your thoughts on this. Who is the surgeon? I'm going to switch to the chat group to see what I can see. Who is the surgeon? Okay, I'm waiting for. Okay. I can see some people going. So there's a boy's mother, surgeon is mom, his mother, mom, mother. Okay. I'm loving these responses. So I'm going to interestingly challenge it a little bit. So the truth is traditionally the answer is the mom. Absolutely fine. Usually a lot of people don't think straight to this, right? I guess I'm talking to quite a lot of educated people around EDI, really good, which is nice. Traditionally, the answer has always been the mom. And yes, I hear that. And it's good we're beginning to embrace that concept that yes, moms can be surgeons and things like that. Actually, before I move on, shout out to Dr. Kathy Appleton, who's doing a great job with moms or people returning to work or people on mat leave or parents in general, and trying to see how we can support them within Northamptonshire, by the way. And, a lot of the early career doctors, that has really helped with retention in terms of what opportunities are out there. What can I speak to my employer about or not? And these are all components that all fit in nicely into EDI if we're thinking about it. Thinking about return to work. Some people are going back to work with full on calls. Are we really thinking about, how they would cope? So yes, that was a plug for her. And, Sean as well helps on that. So thank you for that. So yes, the mother. But what if I said, in this day and age, if we're thinking wide, it could possibly be the fact that this boy has got two dads. Why not? Yes, exactly. Okay, some people are beginning to bring that in. Absolutely. So we need to, grandfather, interesting. I didn't see that big coming. I'd love to understand how grandfather, but please explain that. But the truth is, oftentimes, yes, we're in that frame of this is what is right. Mother is the right answer traditionally. But actually there could be other things to it. And this is where we need to encourage ourselves to be more open-minded, really, especially in this day and age, and challenge ourselves. Are we seeing things from different perspectives or not? And also, if we need to go down the cultural pathway, there are some people that, everybody, anyone from, so I was born in Nigeria, by the way. I grew up in Nottingham, but I've still got that Nigerian element. Everybody that's older than you is your auntie, your uncle, and usually some of them will take you as a son and daughters. So could that have been used in that context as well? But my point is there are different ways one could answer this particular question, really. So again, we need to be open-minded when it comes to, different, whether it's working with our students, whether it's thinking about our staff, we need to be more open-minded. And that takes us nicely really into the theme around unconscious bias and microaggressions. Now, usually, I would, have a lot more time dedicated to this, and which is why I need to stress today's session is just me touching on important components here and there for you all to go and think about, to begin conversations within your surgeries. We had a bespoke session, and usually the bespoke sessions I do tend to bring out a lot more information than people usually expect, and they get to work on it as a group, really, and that worked beautifully for us at our practice as well. So something to think about, thinking about biases. There are various biases, and also the microaggression side of things. I usually talk about microaggression or microactivities. We can have micro affirmations and we can have microaggressions. Okay. So, the positive things you do on a subtle level, that we often just take for granted, opening doors for people, just normal day-to-day, respectful things to do. But actually there are microaggressions, really subtle tones here and there, and we see that displayed in different forms. I think for me, one of the ones I still got it this week. So I do endoscopies, and one of the patients was like, "Oh, so where's the doctor?" I'm like, "Oh, yeah. Oh, like the doctor." Yes. I mean, this is a safe space. I'm happy to share, some of these things that happen. It doesn't get me down, but instead it actually opens my mind to what is actually still happening out there. And so you look so young to be a doctor, or your medical knowledge seems a lot more than your age, really. What were you expecting with my age? So all of these subtle things that are said, and it is a compliment, talking about the medical knowledge, but really in the grand scheme of things, it shows there was a certain expectation and, of a certain age. And yeah, anyway, so there are some micro things, and all of these fit into the whole unconscious bias. I don't take it, like I said, I don't take it personal, but I need to recognize the fact that a lot of colleagues on this call go through this on a day-to-day basis. And even if we think about, interactions with patients, I don't know if any of you can relate, but there are some patients with someone like me where we have to almost use a certain scientific, explanation on a certain term, and then break it down and explain. It shows that you know what you're talking about, because clearly that is what then builds trust when you think about the patient, really. So there are different examples on a day-to-day basis. And even if you think about things like our registrars as well, there was this whole phase where they used to be called trainees. And if you're on the phone trying to book an appointment, some people will say, "Oh, that appointment it's with our trainee who's training to be a GP." Now, mentally, for our patients, like for some people anyway, it gives that insinuation of, oh, okay, maybe they're not good enough to be an actual doctor. And whereas these are trained doctors who are just training to become GPs. But then, changing the term to registrars, I think that for me has done a lot of more good, really. But it's to encourage everyone to then embrace it. Because if we're thinking of the microaggressions from different angles, already coming to the appointment, I'm only just coming to see a trainee, that already sort of affects expectations really. And if you're to add the fact that maybe the registrar is an IMG, possibly with a very long name, like my full long name, that already, for some people, that bias already sets in terms of expectations. So again, it's being mindful of the little things we possibly don't often think about, but these are real examples. Now, obviously with biases, again, there are different types, which I'm hoping you'd have explored really within your mandatory trainings. But I think the key thing for me is being able to encourage yourself to say, okay, these things do exist. I need to be open enough to have real conversations about it and not just turn it to banter, because that is now the new thing. Another one I got was someone who was literally on TV. There were some animals from the jungle, and then the person asked me, oh, does that remind you of home, Toyosi? Does it really? I also have to travel to the zoo the same way you have to, so all of these, and then some people will laugh about it and all of that. But how do we address it? A lot of you on this call would have seen some sort of subtle, whether it's microaggression, whether it's bias in play, but you don't laugh about it and turn it to banter. But I want to encourage you to see how you can nicely, usually for me, what works is asking the person back a question like, oh, like, not directly as someone that's a bystander, ask, a question and, just to clarify, maybe it'll give that person a moment to rethink what they actually just said. So let's be mindful of that, unconscious assumptions, how we engage with our patients. Even when we think about, there are some patients, right? You see their name, and then some people are like, oh, that's a frequent flyer. What if that's case they're calling you for that day is actually something that's, between life and death, but how you approach it might be a bit more chill because you assume, oh, that's how they always call. So we need to always think about this really. This affects, trust, safety, care quality, and like I said, impact both staff and patients. Okay. So at this point, I would love a volunteer. We're going to do a role play. I would love a volunteer. Let me see. Would I be able to, Craig and Mel?
Yeah, if we do you want me to just, I can open it up so I can turn everybody's cameras and mics on.
I just need one volunteer. Yeah, it's just to open up that person's.
And somebody raise their hand.
Yeah, it doesn't matter if you're, regardless of what you are, we can make this work. Yeah, so whilst I'm waiting for a volunteer, someone has said they should now be called residents. So yes, that's an interesting conversation in relation to our trainees or previously called trainees. So within, like, in general, they're resident doctors. Yes, based on the BMA and all of that, they're resident doctors. But within the RCGP scope, I would love to address them within GP land. They become our registrars. But yes, in general, instead of saying that's a junior doctor, that is where resident comes in really. So yes, I'm still waiting for a volunteer, please. Please. And essentially, I'll be a patient and you get to be whoever you'd like to be. Interesting question. How can they be residents if they don't sleep in the practice? I'll let you ask BMA that. Oh, Oana has volunteered.
I raised my hand. I don't know if you also hear it. I hear like a ringing. I don't know if it's related to this call or not because no one else is calling as I'm in this meeting, but I'm happy to volunteer. I hope you don't hear what I hear.
No, I can't hear anything else in the background. Is everyone fine that they can't hear anything else in the background?
Yes.
Yeah, okay, brilliant, brilliant. Right, okay, so Oana, what role are you I don't know whether I should really do this with you though. But yes, what role who are you, or Anna? What role do you want to assume?
Am I the patient?
No, I'm going to be the patient.
You're going to be the patient. Am I going to be the doctor?
You tell me what role you'd like to assume.
Okay, I'll be the doctor.
You do a lot of community work, don't you?
Yes, I have no clinical experience practice.
that.
I'm not trained, just so you know.
I know that. I know that. I know that. So Oana, I know organizes a lot of events, as she also showed you guys, beautiful pictures there. So I will be a patient and I will possibly meet you at an event. Okay, I'm going to switch characters now. Okay. Hello.
Hello.
Me, pain. I have pain. Pain.
Are you hurt?
Yes. Yes.
Where are you hurt? Could you tell me where are you hurt? What is hurting?
I don't understand. I don't understand. Yes, that's what is. English.
You don't understand English.
Small.
Is there other language we could try this in?
Okay. Pain. Pain. Me.
You're in pain.
Me, child.
You're a child.
No. English, but she's school now. She's school.
Your child is in pain.
No, me.
You're in pain. You're a parent and you're in pain and your child is in school.
Yeah. Help, please. Help. Is that hip?
Do you have hip pain? Just so you know, you're constantly freezing. So besides having the language barrier, I have some digital issues too now.
Okay, we'll stop it there. Interesting, you pointed that out actually. So how did you find that?
Difficult.
In what way?
In the way that even if I'm the medical expert, I need to understand what's happening to my patient if I want to help my patient. And clearly, if my patient cannot express herself, we have problems. I wasn't sure, is the mother in pain? Is the child in pain? Is the child in pain at school? So it's very difficult to understand the patient.
Absolutely.
When it's unclear who needs the help and how can I provide the help? What other language we could speak in?
Yeah, and that is all, those are all valid points, really. Thank you for volunteering. What
You're
do
welcome.
people think in the group? I'm happy for you to pop the chat group. What were your frustrations, even with watching that? Someone reckons I'm possibly pregnant. Okay, interesting. And that's the power of communication in terms of, what is non-verbal versus verbal, that is the power. So based on that, there's an assumption that I was pregnant. Any other thoughts to that? You felt helped, even watch. Exactly. Yes. Any other thoughts? Had to not look confused on your face, which isn't very welcoming or empathetic. Absolutely. Child usually translates. Yes. Okay. I'm happy. Thank you for this point. So I'm happy for you to keep bringing these points. But this was a whole, I was in pain. I was trying to tell us a child was able to interpret, but they were at school. Okay, that person got me right there. Yes. So would pointing to areas help identify? I'm a good actor. Thank you. Okay, so I'm happy for you to keep reflecting on this. But I think the key thing here is it was frustrating for me as the patient, for Oana as the person trying to help. Now, this is regardless of the context, okay? Now, Oana could have been at a community event, which was the scenario there, and the woman was just trying to get some kind of help from someone, and that is the background to that. And indeed, she was trying to pass the message that she does have a child who is at school, 8 years old, but speaks good English, but she was just frustrated she could not express all of that. So she was hoping the child would do the translation for her. But again, even in community, you have that power to then signpost. But in your signposting, to then possibly, instead of saying, oh, just go to XYZ GP, or wherever the service is, in signposting to let them know, oh, they can get access, hopefully, to interpreters, or even if you're doing the direct signposting, if you're maybe calling the GP surgery out of concern, let us know that there is that part of actually language is a problem. We don't know what language, but we need to start thinking about it. And that would help people get things in place, really. Obviously, if it then means, whilst we're doing the consultation, we're able to arrange translators, that information would have been passed on much earlier on. And I think that's the mistake a lot of us are making now, where it's mostly when the person gets to you right in front of you in consultation, and then you go back and forth with broken English. Some people use Google Translate, go back and forth, and then it's like, oh, okay, maybe my 10 minutes could have been better spent just getting a translator early on, really. So absolutely, there are different components to think about. One is language was a barrier. Two being some people genuinely use children to translate. It doesn't have to be a child less than 16. It can be anyone. But be careful about that. And this actually came off, there was some information work was done across Northamptonshire a few years back. And people gave their feedback. And the idea was actually, just waiting or using the translators come with, whether it's their husbands, their children, might not always be a great solution, really. And I'd say let's try and avoid that as much as possible to give people the right environment to be able to share their concerns, whether it's from a place, even if you're thinking culturally, there are some things that a woman, I'll use women, a woman's health concern as an example. There are some things that they might not be able to express in front of a child, really, trying to use certain words because they don't want that child to be exposed to that sort of information. So we then go away from actually providing them the actual care they need. So we need to try and deviate as much as possible from trying to use translators they come with. Let's go the extra mile to make the right arrangement, really. So actually, translators that are not family. Oh, I didn't see that comment. It's gone off my screen. Okay, I'll continue. So anyway, it's important to think about these various things when it comes to offering the support we need. And sometimes when we think about the support we can offer people, we'll talk a lot more about the language side of things in a bit. But sometimes we automatically have that bias that, oh, because they are XYZ, then this is possibly what the problem is. And that limits us mentally to what we can truly offer these patients. So we need to be mindful of that. Now, in terms of just tackling unconscious bias, again, because I'm mindful you've all possibly done your different trainings. The general thing for me, ABC, accept it exists. Break the pattern, okay? Think of creative ways to break the pattern. And C for me is choosing inclusivity. Okay, and this is a decision you almost have to make on a daily basis. Even from a clinician facing, like as a clinician myself, there are sometimes I'm like, I'm not going to let the name of a patient or what I've already read in their notes. I'm not going to let that affect the kind of consultation, what they get from me right now. What is the issue right now? Let's focus on that. Having said that, a lot of us think of biases and go, oh, it's not all negative actually. Biases can be positive. A good example, again, I'll use hypertension as an example. There's sometimes for some patients, certain presentations, you see the pattern, blood pressure high, things like that. You see the name, you already, for me, I can sometimes work out, oh, what country they're from. And usually when there's that Afro-Caribbean link, I can pick that up as well. And then have some tough conversations that some of my colleagues would have possibly treaded, a lot more carefully, but actually, no, let's address the problem early on. But that bias of being able to identify that right there and then actually helps. And also helps in your management plans, actually, because there are certain medications that can be used or not used. So not all biases are inherently negative, is all I'm trying to say. Okay. So which leads us on to the third theme around inclusive communication. We've talked about this. Interpreters, let's try and use this a lot more, as much as possible, really. Health literacy matters. People have touched on that. And thinking about cultural sensitivity. Now, this is where I think our community connectors also come in. Because sometimes what we think we know about cultural sensitivity might not really be what there is to it, but actually sitting down with different communities to understand. Obviously, this is going to be a lot of work, but actually, I think it will go a long way when you understand their needs, how they want to be addressed. People are now thinking about, the digital side of things. We're sending things on social media, as a practice, we're texting. But actually, is that what, not all our patients will be able to, engage with that. So we need to really assess what we have currently and think about what we can do to make things better. And this, again, is something I believe we've all touched on. So, but again, it would be lovely to know what you think are the biggest issues you have. Well, I believe someone else has had it in their slides, really. But again, I'm happy for us to touch on that if you do want to point out anything around there. It'll be interesting to see practically, because collectively we know these are issues, but it'll be interesting to see what we think, is like the main thing. And I hope that would again drive a further conversation around actually more work needs to be done in this area. It's not saying everything is not important, but it'll be lovely to know what areas we need to focus on and then, try and improve things from that perspective. Now, from the language side of things, I think personally, one of the examples we were working on, and I know some people, we need to be careful about devices and all of that, So I am trying to look at what can be done practically in terms of devices that we can use. We did get one, still putting it together a protocol really to see whether we can go live with it. But for me, it's beyond the device. Because for me, I'm thinking when a patient presents, how do they know that you offer a translation, they can get an interpreter sorted? How can they point out what language they speak? It's things like this. And okay, if they do that on this presentation, what are we putting in place? And I'm hoping we can put an icon in place that would help us, remind us that, okay, this person needs a language, an interpreter, and what language it is. So we don't have to keep repeating that over and over again. But then I've had to go a step further, really, and think about it. A lot of our entries, or we've got a total triage method, as it were. And a lot of it is actually, if it's coming through Anima is what we use. I'm not trying to publicize them, but that is what we use. But I realized that whilst patients can see some of the entries in other languages, it doesn't always come through to me as a clinician that this person speaks XYZ or has had to fill this form in a different language. So it's me thinking about different stages of a patient's journey and saying, okay, how can we make sure? Because if I know they need that, they have that issue, that they've accessed that online consult with a separate language, then already I'm already thinking about, okay, what measures are we putting in place? So we've had to have a meeting to see how we can try and address that, and conversations are happening there. And I'm hoping they improve that part of things, really, because what it then means is patient's care is better. We're not all looking surprised, when it comes to seeing the patients and realizing, oh, they speak another language, or, So I think it's important to think about that. Thank you so much for the entry so far. So language and digital exclusion seem to be head in head. Okay. Health literacy is there. Okay. Again, happy for you to keep up with this conversation, really. I'm mindful of time, so I'm trying to whiz through. I really, really wanted to hear from anyone else, really, in terms of one thing they're doing across the county. But I know we've heard from other, different people, but I really wanted to hear from a clinician. I don't know if I'll be brave enough, whether a clinician, but someone in a surgery, to let us know what they're practically doing to address any of these concerns. I don't know if I'll get a volunteer. If not, I'll move on. Because it's interesting that we've actually heard from a lot of things happening outside, and trying to help us within the surgeries. But practically, what are we all doing within the surgeries to address some of this? I don't know if anyone is brave enough to share. I'll possibly move on, but send me an email if you've got good examples, and then we can take it on from there. Because this is the other thing I've come to discover. A lot of us are doing amazing things, but in silos. And I'm looking forward to a Northampton share perspective where we're beginning to work a lot more collaboratively, really, with our various sectors to try and implement change and not reinvent the wheel, really. Okay? And I think for me, when I was trying to think about the EDI theme around patient care, I'm thinking, thinking about quality of access, diversity of needs, and inclusion in care. I'm going to stress this bit about inclusion in care because there is a whole narrative we need to support a lot more of, which is around getting our patients involved in the design, co-production of, things we want to implement. Oftentimes, a lot of us are talking to our patients, sending messages out, everything. It's almost one directional, And I think we need to take a moment to take our PPGs seriously, engage with them a lot more. And even beyond PPGs, think of creative ways to embed and make sure our patients are part of the journey with us, really. And that makes them feel a lot more included in the whole process. Right, so theme 4 is workforce inclusion. So a lot of us talk about EDI, and, we have, equality, diversity. And when I think about diversity, for me, it's diversity of thoughts, diversity of ideas in the room. So it's not just necessarily what people, but beyond that, there's a lot more when it comes to diversity. And for me, oftentimes we fall flat when it comes to the inclusivity part of things. So people are part of this organization, they look like a diverse workforce, but what are we doing to make sure people are feeling included, that having that sense of belonging? And I think this is somewhere we really genuinely need to work a lot more on. And one of the basics I'd always start with is names, names. And interestingly, I think this is one area that, yes, we need to work on, but practically, how would people love to be addressed? Oftentimes we don't focus on that, but it goes a long way. I was doing one of these sessions, and I must have called this person by their full name. And for me, I was just going by what was on my register, to be honest. And interestingly, she ended up breaking down to cry because apparently for her, within the NHS, she'd been working in NHS for several years. That was the first time anyone had called her, taken time to call her full name. And it meant a lot to her. But also in that moment of reflection, she also realized that actually she had, that was very important to her as an individual, but she had allowed that part to shrink just to try and fit into other people. Whereas, what if we flip the narrative to say, as an organization, wherever you are, we want to come and meet you where you are to address you as you'd like to be called. We will all make the attempt, no matter how complicated it seems. We'll all make the attempt to engage with you. So names for me are really important. Some people would then go, oh, I'll just call her Bob. I'll just call her. No. Nah. I think we need to change that narrative, put a bit more effort into it, and actually take it as a bit of an interesting way to build relationships, because everything, when you really truly look at EDI, has to do with relationships. Okay, and when you're able to build that relationship to the point where you have that safe space to engage with that person, it won't become, this person talked to me because I am this or I am that. Actually, you're able to address sensitive issues together on a journey together without it hurting anyone as such, really, and becomes a learning experience for all parties involved. So yes, okay, name, I've talked about that. Another popular, thing that tends to come up in some of these sessions would be around Christmas parties. Okay, so a lot of people will call it Christmas parties, but then is everyone really celebrating Christmas? So to make it a lot more inclusive, some will say, holidays, or the New Year party or something like that. But regardless of what it is, you need to think about how your staff is actually being represented, and do you actually listen to staff? That is important. Okay, it helps when we think about inclusion. That is one of the key things that keeps flagging up. Are they represented? Are they feeling heard and respected? So one of the feedback we got as an organization was around, I'm still going back to the Christmas party, New Year party, any party you want to use. I'm still going back to that theme. One of the feedback we got was that some people preferred it being like after Christmas, the Christmas season, because a lot of things actually is happening in that time and all of that. And, we're able to listen to that feedback, take it on, make adjustments, and people had a great time and felt the discussions that came up that was was really good and valuable. And people, felt like they were being heard. Suggestion box, we've come up with that as well in the surgery. People are, engagement with that is interesting. We're trying to get more people to engage with it, but they have that option to have their views heard, really. So again, we need to think about inclusivity when we're thinking about the workforce, and inclusive leadership goes a long way, really. So I think for me, we're skipping this role play, lots of time. I think for me, one question I'd want to find out from you all really is, what would make you feel more included in your current practice? And then to then take, if you can pop the answers on here or using Menti or Teams, and then to then take this conversation back to your surgeries, really, and then go, okay, let's sit down and just let's get to know each other. How do you really feel as a human being? If you're able to relate with people, able to understand, how many cats, dogs, whatever it is that's important to that individual, you will become, your relationship will be in a better place for you to address sensitive things and also bring about positive change for our patients, because you're able to work more collaboratively. And interestingly, when people feel included, they're more likely to go the extra mile for you, for the organization as a whole, really. Because the truth is, everyone brings so much value to the table. I don't believe we're paying everyone, the value of what we all bring. There's so much goodwill within the industry, and I appreciate that, really. But I think we need to think about that a lot more. So I see something about recognition. Okay, so recognition is an important one. I don't know if anyone does like it'll be interesting to get people's thoughts on, employee of the month or staff of the month kind of schemes. Does that actually help? Because, I've heard different variations of that really. So I think for me, it will be important to find out what is important to you. Or like I said, what is important outside regular day-to-day work. Time and attention, absolutely. Give us time to connect with each other. Every second is accounted for. I can so understand that. Some people have their coffee breaks embedded into, you're all having coffee breaks at the same time. In some places, it's well attended. Some places it isn't. I've heard there's the opportunity of thinking about, like a team huddle. I don't know if that actually helps. It would be lovely to hear. I think it's something that can work, actually. It works beautifully. It would be lovely to see if people are able to have things like that. Everyone joining in when there's staff activities, absolutely. And when it's staff activities, we're thinking of staff activities within the surgery, but also like external, events, picnics, things like that, where staff get to come together. It would be lovely to come, together and then, get everyone on board. There's been invited to socials that don't revolve around drinking alcohol. Thank you to whoever brought this up. This is an absolute interesting point that often gets overlooked. Now, there's some people that would not drink alcohol, and it's okay to respect that. But I think that needs to be thought about really when you're thinking about the types of socials. It's not saying you're going to go somewhere that doesn't have alcohol at all, but making it very clear that, there's a lot more opportunities to engage and relate without waiting for it to be time to drink alcohol. There's more that can happen really. So be creative around your socials is what I'm getting at. Protected staff breaks, cake. You can't go wrong with cake. I love that. Daily conversations, absolutely. And the interesting thing with the daily conversations, I find this powerful because it helps take you on a journey with that individual. Okay. And I'm intentionally taking a moment to really spend time on this bit about workforce inclusion, because a lot of us are struggling with whether it's retention, seeing a great turnover, and oftentimes we're not paying attention to these subtle things. Well, subtle to an extent that can make huge differences, really. And I think if you invest a lot more into some of this, you would see better outcomes for your patients and for your practice as a whole. Regular communication and updates, absolutely. We changes from management with consultation. So when you're implementing change, take people along with you. It's not always easy, and I appreciate that. But thinking about your key stakeholders, take them on that journey because it will make your life a lot more easier, really. Time for well-being tasks and appointments. Think shout out to Jamie at my practice, Jamie Green, who's trying to get us to do like pack runs and things like that. I must admit I'm yet to go on one. But I am making this public commitment. I will attend. But you know what? Creating that time intentionally for well-being opportunities, making them know, making your staff, whether your partners, salaries, regardless of your levels, admin, whatever it is, making each person feel valued, I think will be really important. All cultural events, okay, being made as important as Christmas, okay. So thank you for these variations. And again, someone said not a park run. It's okay if park runs are not your thing. And that's the thing, find your tribe. Create that within your environment. And I'm hoping you have leaders that can listen to you to help bring that alive. So again, remove status barriers. Oh, that is a big one. So these are practical things really that I'm loving the fact that we're feeling safe enough to touch on it. But beyond that, I want you to go back to your different practices and see practically how can we begin to think about this? What are we doing right or not right in this area? And actually devote time to improving on this. Right, so when I think about EDI from a staff workforce perspective, E for me is engaging with everyone. D is developing inclusive teams. I is to inspire belonging. Remember what I said about people, yes, fulfilling the E and the D, but not having that place where people they feel like they actually belong to. They're just there because it's going to pay their bills, really. We need to change that narrative as much as possible. And it might need a bit of investment, sometimes, and it's what investment of time, investment of funds. If you're going to take people somewhere nice, things like that. I'm not saying do that every month, whilst that would be nice. But the truth is we need to think about these things. So practical action plans, really. I will be wrapping up soon. From a patient perspective, I'd love you to review your patient access policies, especially with the changes that have come into place from today. I think that becomes even more important, really. On different levels. But also, I want that open reflection on bias, within team meetings. I'm not saying every team meeting, but being able to create that safe space. It's important to reflect on that, really. And for people not to feel judged for saying certain things or feel inferior for sharing their minds, how they feel about certain things, really. I want you to audit your communication materials. And when I'm saying audit communication, it's for both staff and also patients. Okay, how are we doing on that communication front, really? And someone rightly said, that communication when it comes to changes or just communication in general management is something we need to think about. Share lived experiences for cultural competencies. I mean, an idea that just came up is, how about, having a day where, you're different foods. I'm sure some practices do it, and just actually share, your cultural experiences, lived experiences, and just to, again, develop that relationship. And I have this thing about 3 Fs. So if you're able to do anything that's linked with food, fashion, or fun, I think you would cohesively bring people together, really, within your organization. And I've also included nominate an EDI champion and aim for, an annual practice review. Just have a sit down and let's just talk about things, really. And the EDI champion for me is there to look at different things. For those of you going into research or being involved in research, because that's now a big thing, thinking about, are you thinking about the EDI aspect of it, getting a fresh pair of eyes to, overlook certain things, really? I think that will be important. But EDI champions to feed into your different components across the practices will be important, really. Overall summary, EDI impacts patient safety and trust. Biases and microaggressions must be addressed. We need to call it out, really. It's not always easy, and that's the other truth, actually. Sometimes it's challenging. Sometimes, honestly, I find myself going, maybe I need to choose what battles I fight. Do I have the energy for this, really? So, because some of it can be quite draining, trying to address it. But truth is, it must be addressed. And this is the other thing. It doesn't just have to be addressed by the person that has gone through it. Any bystander should feel confident enough to call it out, not in a confrontational manner, but should be able to call it out. Inclusive communication will boost engagement. And, a supported workforce actually translates to better care for our patients. And I'm hoping we can see that thread, going across. And overall, EDI for me, at the core of all the things we've said today, is about us focusing on change. It's not another tick box